So you've got knee arthritis, you've been told it's bone on bone, and the doctor says you'll need a joint replacement surgery, but in the meantime, here's some cortisone shots to get you by, and when it's bad enough, we'll operate on it. Let me explain exactly what's going on in your knees and help you understand why that might not be the best option for you anymore. I'm Dr. Jacob Knapton. I'm a doctor of chiropractic here in Pleasant Grove, Utah, and I've had a focus on regenerative medicine for my entire career. I've performed over 5,000 shockwave treatments, and we've seen incredible success when it comes to knee arthritis specifically. So, knee arthritis, let's talk about it. What is knee arthritis? What does bone on bone even mean? You have your knee joint, and the knee joint has fluid, which acts as a cushion mechanism, and you have a layer of cartilage on either end of the bones in your knee. Okay, they provide friction resistance and cushion for that knee to function. When you have arthritis, the joint begins degenerating. And what that means mainly is the volume of fluid decreases inside the joint capsule, and that layer of cartilage is thinning inside the joint capsule. So those are two things that provide a cushion to that joint, but when you lose those things, you start to develop pain and inflammation, and thus you have arthritis. The reason we call it bone on bone is if you look at an x-ray cannot see the fluid, an x-ray cannot see the cartilage. So you're just assuming the thickness of the cartilage by seeing that joint space narrowing. And when that joint space is absent, it can be diagnosed as bone on bone. But let me draw a picture and help you understand why that might not be as significant as you or your doctors may have told you. This is a systemic review published back in 2008. A systemic review is basically a group of researchers who look at the available research, all of the data that we have, and they rule in and rule out different biases. They take the highest quality evidence and they put it in one paper and say, this is the recommendation. So they've studied over 700 patients, and these results are astounding. Listen to this. Of the people with radiographic knee osteoarthritis, so people who have arthritis visible on an x-ray, the proportion who had pain ranged from 15% to 81%, depending on the study. And going the other direction, the people who had knee pain, the proportion who had arthritis on x-ray ranged from 15% to 76%. That's a huge range both ways. So we could be talking arthritis and out of pain, 15% of you who have arthritis on an x-ray have pain. Or it could be 80%. And vice versa, looking at people who are in pain, 15% of you will show an x-ray arthritis, or 76 will have arthritis on an x-ray. That is a huge number, and it's not dialed down enough for us to medically say this equals this. So that's the debate now. And their own conclusion, they say, they wrote knee pain is an imprecise marker of radiographic osteoarthritis, and radiographic osteoarthritis is likewise an imprecise guide to whether pain or disability will be present. So, long story short, they say if you have arthritis on an x-ray, that doesn't mean you're going to have pain. And if you have knee pain, it doesn't mean you have arthritis. That's just not enough for a doctor to come in and say your knees are hurting, let's take an x-ray, you've got arthritis, let's give you a cortisone shot. This is the part that blows my mind. If you understand the anatomy, you will know that cartilage does not have nerve supply. So thinning cartilage does not cause pain. You don't have pain because you have bone on bone arthritis. Cartilage does not cause pain. What has nerve receptors, what does cause pain, is muscle tendons, muscle fibers, ligaments, the subchondral bone and bone marrow. This basically, the result of a lack of fluid creates a requirement of more muscle strength and tendon strength to move that joint. The analogy I put is like driving a car that needs an oil change. When you have fresh oil in your car, all the parts run smoothly and nobody's worried about the pistons, nobody's worried about the engine, the moving parts. But when that oil is low, you've lost lubricant. And now it requires more effort for those moving parts to function, and you risk causing damage. It's the same way with knee arthritis. In that knee, when you have degeneration, it requires so much more out of those muscles and tendons. You start to develop bone spurs. You start to develop nerve ingrowth and tendon degeneration. You start to have these changes to the knee that are all soft tissue related, not because you're bone on bone. So, cortisone. Why is cortisone legit? Why it works? Why did I get a cortisone shot and it worked and it helped? Because cortisone is a strong anti-inflammatory, and it's great at being an anti-inflammatory. But the problem with knee arthritis is inflammation is just the signal. It's like the fire alarm that's going off in your house, and if you took the batteries out of the fire alarm, that doesn't solve the problem. There's still a raging fire in the living room, and that will just continue to grow even though you've shut off the alarm. So your body's inflammatory response is a natural signal, it's a natural alarm that something is wrong and something is going on. So when you get that cortisone shot, it's like taking the batteries out of that alarm, and you go on for maybe 6 months feeling great, but oftentimes when that cortisone wears off, you're in more pain than you were in before. So you get a second cortisone shot, but now your body's building up a tolerance to it and it may not last as long. And you keep getting 3 shots and 4 shots until the cortisone stops working. Now you're in trouble. So cortisone, it works temporarily, and in knee arthritis might not be the best option because you're just masking the pain and putting off the inevitable. That's not a medical plan. That is procrastinating, that's ignorance, and it's not leading to a solution. And in my opinion, I would never feel comfortable putting myself or any one of my patients on a medical plan that set them up for failure. Now let's talk about Shockwave. Shockwave is a non-invasive, drug-free, and effective modality that treats knee arthritis. There's actually an abundance of research around shockwave therapy for knee osteoarthritis with incredible results. And what I want to focus on is the 2 things that shockwave improves is pain and function. When these patients that they've studied had undergone shockwave treatments, they had less pain and they had more function in their knees. Those are the 2 things that will decrease that lead to a knee replacement surgery. So if we have a conservative, drug-free, non-invasive option that will give you more function and less pain, that's a medical treatment plan. That's a plan right there. So what is Shockwave? What does it do? It's an acoustic sound wave. A machine creates a sound wave. That sound wave is condensed to a focal point, and at that focal point, it causes a pressure change that's capable of penetrating into your tissues. So we can target areas within the knee capsule, within the knee joint, with this energy from the acoustic shock wave and signal a different type of biological response. And when we apply shockwave to the knee, that biological response that takes place in your body stimulates your body to regrow blood vessels. It stimulates your body to send healing nutrients to the area, growth hormone migrate to the area, certain cells to help rebuild tissue migrate to the area, and you get less tendon degeneration, and it creates a healing environment. So shockwave is a natural way to stimulate your body's native response to correct these issues. And they've done studies where they've put shockwave up against cortisone and they've compared the 2. And both actually have equal outcomes in pain right off the bat. So now we have a drug-free, non-invasive option that gives you just as much pain relief as a prescription anti-inflammatory medication. But in the long term, this is where it gets interesting. Cortisone decreases chondrocyte activity, which means we're decreasing your body's ability to rebuild tissue. You're weakening the tissue integrity. Shockwave increases chondrocyte activity. So you're building up, supporting the body's natural healing response and allowing your body to rebuild and strengthen those tissues. So, as you could assume, in the long-term outcomes, at those long-term follow-ups, those patients who had shockwave therapy were significantly better off than those who had cortisone injections. So it's a question of going back to what causes pain in knee arthritis. It's the soft tissues, it's the joint tendons, it's the muscle fibers, it's the extra mechanical stress that the knee joint requires because of the degeneration. But if we increase chondrocyte activity, if we increase fibroblast activity, if we increase the body's response to rebuild those tissues, then you have a long-term solution that naturally helps your body recover from degenerative arthritis versus cortisone injections that put it off until they stop working. Bottom line, being told that your x-ray shows arthritis and it's bone on bone, it's not an end-all be-all. That doesn't mean that you're cooked. That doesn't mean that there's nothing we can do for you. Come in and have an evaluation and see if there are conservative options for you. We have conservative options that will help you recover and heal the natural way. Get an honest evaluation. Worst case scenario, you leave knowing exactly what's wrong, but let us take a look at your knees and see what we can do to help.